Welcome everyone. This is Dr. Jaitly, your cardiologist on your favorite website, MuniMeterHealth.com, which is dedicated to educating you about the human heart and its illnesses across the globe from one end to the other, primarily on two social media channels and of course on your apps that you follow us with. So once again, I welcome you to enhance and advance my my initiative on clinical education, patient education together to improve the clinical outcomes through my website, MuniMeterHealth.com, which is our website primarily for enhancing knowledge. Remember the first housekeeping rules, which I always advise. This for interns, residents, and fellows, and my dear colleagues. Just remember that this is not a replacement to the text. It's a supplement to your text, so be advisable on that. And two, also for people, general masses who are following, it is not a treatment advice tool. This is mainly an educational tool only to enhance your knowledge about the heart and its illnesses, and of course make you more aware about the heart, so that this way when you go back and discuss it with your doctors and your staff, you can understand the tests better, you can understand the prescriptions better. That's the whole idea of improving the patient health literacy through this format. So having discussed that, let's understand what is acute limb ischemia. Now we have talked about chronic ischemia, and this is limb ischemia. So in other words, what is acute? This is, again, remember, it's an emergency, and when that is occurring, obviously an acute limb ischemia needs to be immediately managed, but you have to ascertain where the problems are. So it could be, as I said, it could be, let's look at one of my favorite diagrams here. For instance, if you look at this diagram here, like in the aorta, the obstruction could be here, it could be down in the aorto-iliac region as we've progressed further from the iliofemoral junction, or it could be in the femoral superficial and deep femorals here, and as we progress further it could be in the popliteal region, etc., etc. So depending upon where the obstructions are, the symptoms will correlate with those patients in that region, and you can see the correlation is as following. It will be predominantly in the buttocks and the hip region in the if the obstruction is the aorto-iliac region. It'll be in the upper thigh region when it's in the deep femoral region. It'll be in the lower thigh region when it's in superficial femoral region, the obstructions are. And then popliteals, depending upon whether it's proximal or distal, you'll have upper calves or lower calves involvement here, and the pain and the intermittent claudication will be there. Again, all of this could be confirmed by CTA and then by MRI, as we know. But remember that most of these patients will require medical management first. The aspirin and the heparin in this setting, especially with acute limb ischemia, one has to give antiplatelet agents and heparin. But remember that in chronic ischemia, just a word of mention I forgot to mention there earlier. In chronic ischemia, remember that when you have chronic PAD, these patients can also benefit from controlled exercise programs. So you have to offer a controlled exercise program in these individuals, and that really helps a great deal. So any kind of what you may call any kind of rehabilitative mechanism to put these patients on treadmill 6 to 8 minutes daily, to the point where the claudication can be just about initiated. You can stop at that point and then actually benefit these patients, because you will demonstrate that there will be an increased pain-free, we call it increased pain-free walking duration of the time. So in other words, the patient was able to walk on the treadmill for 6 minutes, now will be able to walk 8 minutes and then 10 minutes and what have you. So all these, so the walking duration can be helped in these chronic ischemic patients. Now in acute limb ischemia, the number one thing that you will have to ascertain is what kind of an acute ischemia are we talking about. Well, first of all, we need to ascertain where the obstructions are. So having ascertained whether it's by a CTA or by an MRA, we have decided these patients are going for some interventional workup. We need to surgical intervention. So these patients will require to be assessed first whether or not they're candidates for what kind of procedures you want to do. So first of all, ascertain whether they have any muscle involvement, whether they have a sensory involvement, whether they have arterial Dopplers, whether they have venous Doppler signals, and then you decide what kind of a procedure will they go for. So okay, so very important. So let's understand the class, and they're determined by class 1. There's a class 2A, and there's a class 2B, and then there's a class 3. Now, so class 1 will have no motor dysfunction, no sensory dysfunction. Arterial Dopplers will be present, and venous Dopplers will be present, but they have obviously these symptoms. So this class 1 is a viable. Let's put it this way: these patients are viable. Class 2A, where you have minimal, so minimal involvement of the motor. So I will say +1 plus, and sensory also 1 plus. And arterial Dopplers will be compromised, so they'll be also decreased or absent. Venous Dopplers will be present. To class 2B will have more involvement of the motor, and sensory will be more involvement, obviously, and arterial Dopplers will be again decreased or absent rather here, and venous Dopplers will also be absent. And at this point here in class 3, you have no motor activity at all. The patient may have paralysis, for instance, or muscle rigors can be present, so we can call it rigors here. And sensory loss will be anesthesia here, so there will be total anesthesia. Patient, you can stick in a small little needle and patient will not cry in pain, so that's total anesthesia. Arterial Dopplers will be absent and venous Dopplers will be absent. Now this is class 3. So now the treatment plan will be dependent upon what you see here. So class 1, for instance, these are viable patients. So viable patients, they could be immediately put on aspirin and Plavix, and then give them thrombolytic therapy. Start with heparin, for instance. You can start with heparin, and thrombolytic therapy will be indicated in class 1A and class 1 and 2A. So these are both very, very viable patients, so you can start with medical management immediately and pending surgical intervention, obviously. Class 2B, you need to not waste time but straight take them for surgical intervention. But these patients are impending to go into class 3 rather quick, so surgical intervention is highly required. So forget about doing what you're doing here. If the patient's on aspirin, Plavix, that's fine, but just take them for surgical intervention rather quick. So here it's a matter of few hours only that you have that window, because now you have a muscle involvement already. Patients starting to show great sensory loss, and arterial Dopplers are absent. So this is a surgical emergency almost, so this patient is going to the OR rather quick. So remember that. Class 3, here what you have done is seen that patient has already suffered a muscle rigor, anesthesia is already present. So here you cannot do any surgical intervention except amputation, because now this limb is non-viable, and because it's non-viable, obviously this patient will require amputation beyond the what you may call the obstruction, beyond the occlusion of the artery. So once you've determined where the obstruction is, say if it's aortoiliac, whether it's femoropopliteal, so you can do a below knee amputation, above knee amputation, or distal amputation near the shins, etc., can be done if it's only dorsalis pedi, posterior tibials, etc. Those are obstructed because of peripheral embolization, for instance. Okay, so these are your 4 classes: class 1, 2A, 2B, and 3. Class 1 and 2A, they are extremely viable, so they should be treated with aspirin and, of course, medical management while pending for surgical intervention. Class 2B should be taken for surgery rather quick. So remember, surgery here is very indicated. And class 3 is amputation only. Just remember that. So that's where, like we just talked about here in these settings. Okay. So acute limb ischemia can be managed in that fashion. And of course, as I said, try to determine what your ankle-brachial indices are. That'll define certain treatments in chronic ischemia. Also in chronic ischemia, we also talked about how aspirin Plavix has a huge role. Ginkgo biloba is very, very important, and that has been shown to be very important in improving the pain-free duration on the treadmill. And silestazol is important, but again, the heart failure is a contraindication here. If somebody has heart failure, do not use silestazol. Again, this could be on the boards, may not be on the boards, but surgical intervention could be done by endovascular stent placement in these individuals where the atherosclerotic plaques could be compressed against the wall, and the stent is deployed, and the flow is restored here to near normalcy, almost instantaneously, to 95% accuracy or efficacy, rather, I should say. And again, cardiovascular managements for hypertension, diabetes, and no smoking sign is on, as I said, bringing the A1C as close to 7% intra-op and post-op in all settings of chronic ischemia management, or acute limb ischemia, like in this setting. Remember, there are 5 signs, or 6 signs actually, for acute limb ischemia. One is, these are called 6 Ps, very, very important. And one is pulselessness, Second is we call it poikilothermia, which is cold extremities. Paralysis. Then you have sensory loss, which is paresthesias, if you will. So you may call it paresthesia. Will be present. So pulselessness, cold extremities, paralysis, paresthesia, pallor. That means they'll be very pale. These extremities will be very pale. And then you also have what it looks like is painful. Obviously, these patients have a very, very huge amount of pain that's going on here. So once you demonstrate that they have pain, then you look at in these patients pain as well. So just so that you know, so pulselessness, poikilothermia, paralysis, paresthesia, and then pain in these individuals are present as well, and you can use that as the criteria. So these are your 6 P's, and in a nutshell, I've defined on MuniMeterHealth.com the acute limb ischemia management. So stay tuned for more as it's coming along. And again, remember, this is purely an educational channel. It's not a medical advice, but at the same time, just to enhance your knowledge. So this way, when you go into your day-to-day practice, you have a better idea as to what you're dealing with in your patients, etc., etc. Okay, mainly for medical fraternity, but also for general masses, where we have a set of videos for them as well. Again, once again, so long. This is Dr. Jaitly from New York. Bye.